Greetings, this is Dr. Robert Gish talking about liver cancer biomarkers, current and future. I am the medical director for the Hepatitis B Foundation and an advisor for the VVHA. I'd like to thank the sponsors of this meeting for having me here today. First off, we know that early detection of liver cancer is associated with improved survival. This meta-analysis up through 2014 looked at HCC early detection, receipt of curative treatment, and overall survival. It is consistent on an individual basis and group basis that early detection is critical for us to improve long-term outcomes in hepatocellular carcinoma. This gives you a retrospective study data from the SEER database up through 2013. This has to do with screening and surveillance. Remember, screening is the first test and surveillance is ongoing testing. This is typically with abdominal ultrasound and in many cases with biomarkers such as alpha-fetoprotein. The more frequent the surveillance, greater than one or more abdominal ultrasound per calendar year, was associated with improved outcomes long-term, as well as consistent surveillance techniques. Early detection was looked at in a number of different settings. This is looking at 6 months, 6 to 12 months, and greater than 12 months versus no surveillance, showing in a hepatitis C cirrhosis population that early detection resulted in improved quality. Patient and provider and system barriers to surveillance continue to exist and can be improved on an evidence-based level using outreach letters, calls, clinical reminders, text messages, electronic messaging, and improved access to care. HCC biomarkers are going to be the major focus of this presentation today and not to be focused on imaging. HCC biomarkers can look at serum, growth factors, RNA, including long non-coding RNA, microRNAs, and cell-free DNA. There's a large list of different factors that are measurable here that may be useful for early detection. In the far left column, you can see AFP, DCP are in prominent positions, and AFP-L3 would also be considered as a dominant serum biomarker that's FDA cleared in this first column. This is looking at candidate HCC biomarkers in more detail, looking at cell-free DNA, including integrity and quantification, somatic mutations, circulating tumor DNA methylation, which we'll talk about in more detail here, as well as circulating tumor cells and circulating RNA messages, including microRNA. The current and candidate HCC biomarkers are listed here, including AFP and AFP-L3 and DCP. These are FDA cleared biomarkers in the US and in many other countries globally, and are part of what I call the triple panel that have been shown in a variety of settings to be useful for early detection and prediction of risk. These are actually risk markers, not diagnostic markers. And other tests are also mentioned here, including references. HCC Risk Calculators are available online. The dominant test that I use in my practice is the GALAD score, which has been looked at both retrospectively, cross-sectional, as well as prospective studies, and is available on MD-Calc. REACH-B is typically in untreated patients with chronic hepatitis B, as is the PAGE-B score, so their evaluation in other diseases and data are not clear. The HCC risk score, like GALAD score, has been looked at in a variety of different settings, including hepatitis C, alcohol-related cirrhosis, and metabolic-associated fatty liver disease. This is looking at patient-level true positive rate at a 10% screening level, as well as false positive rates. The GALAD score does extremely well in this setting, including 0 to 6 months before diagnosis for early stage HCC. GALAD score looks similar to the Doylestown Plus, with Doylestown Plus being slightly better in a number of these intervals, which includes what's called a fucosylated kininogen, as well as AFP, gender, age, DCP, and AFP-L3. Individually, AFP looks good, but may have a false negative rate that is substantial, as is AFP-L3 and DCP, including a challenge in DCP being not detectable in most patients, but in a subgroup of patients make DCP only, making it useful in this triple panel and calculating the GALAD score. New directions is what we're going to focus on today. Here is a series of research articles looking at circulating tumor DNA and cell-free DNA, but more importantly, the circulating tumor DNA concentration and circulating tumor somatic mutations. There's extensive data that is available here, although none of these tests are yet commercialized. Here we have circulating tumor mDNA, HCC biomarkers. This is methylated DNA. Large number of manuscripts and publications are here. And there's 2 tests that are approaching FDA clearance in the US and are available through pre-testing LDT or laboratory determined tests from Helio and from Exact Sciences. A little bit more on this, including references, looking at the bottom one by Xu et al. Large number of patients, over 1,000 HCC patients with nearly 1,000 control patients. This is looking at a variety of methylation markers with a AUC of 0.97 for HCC detection. Methylated DNA is also being assessed here in viral-based hepatocellular carcinoma, published in Oncotarget in 2017. The AUC here is 0.87, markedly better than AFP at a cutoff of 20 at 0.56, and also markedly better than AFP level cutoff at 12.15, where the AUC is only 0.62. A little bit more on methylated DNA assay, which I believe is the next generation from both Helio and Exact Sciences, showing improved AUC in the upper left corner with 4 marker tests showing AUC that's markedly better than a variety of other tests that are identified. A little bit more data on this methylated DNA assay from Exact Sciences. 450 patients here, 137 HCC patients, 313 controls, with a slightly smaller number set for analysis. Study patient characteristics are along the left side with a variability of both child Pew, race, gender, liver disease etiology. The substantial number of patients here with NAFLD or NAFLD at about a 20% level. Most of these patients had cirrhosis, but intact liver function with a low platelet count and normal albumin level. A variety of different patients were also identified with tumor stage by different BCLC from 0 to D. There's more data here in this assay, looking at sensitivity and specificity. I'd point your eyes to the far right column, where we're looking at any stage AUC at 0.92. This is better than AFP alone, L3 alone, DCP, and also better than the GALAD score. Specificity is quite good, but the really key data point here is a sensitivity of 80%. This is much better than all the other tests and slightly better than a GALAD score at 72. A little bit more on Exact Sciences, looking at early stage in the upper right-hand corner, which to me is the most important area, because late stage is diagnosed by imaging. Early stage can be diagnosed by more frequent or better imaging, moving from ultrasound to MR contrast or CT contrast. HCC, as you know, is diagnosed by imaging, not by biopsy, and you need a contrast-enhanced CT or MR scan. A little bit more data here on the methylated DNA assay from Exact Sciences, using different cutoff levels with different sensitivities in the left column. The multi-target HCC panel with their pre-calculated cutoff had a sensitivity of 67%, markedly better than AFP, AFPL3, and DCP, and somewhat better than GALAD score at 56. I'm now going to move to the Helio liver approach. This works with blood collection and immunoassay to quantitate the triple biomarker panel that we talked about, as well as a cell-free DNA methylation assay, looking at also patient demographics with age and gender and a reporting system. Encore was published in Hepatology Communications, March 3rd, 2022, with a study population of 290 patients. 140 HCC patients, 150 benign liver controls, with a few patients excluded to the following 122 and 125 for a comparison group. The AROC for the Helio liver panel is 0.94, superior to AFP at 0.85 and GALAD at 0.9. Sensitivity was better than AFP and GALAD at similar specificities, as well as exploratory endpoints. Clinical characteristics are highlighted in this table. One thing I would like to highlight here is a small number of patients with fatty liver disease. Other, in my opinion, is going to be most likely fatty liver disease, but could be a mixture of fatty liver disease and alcohol. Early stage, this is the critical issue, 30% at diagnosis. This is really moving a substantial number of patients from late stage or non-curable, non-resectable, non-transplantable patients to patients with more likely to be curable. A little bit more here on a multi-center validation blinded study for Helio moving liver tests using blood specimens from 247 participants with a very high specificity. This is critical because of what can be done with harm, including the harm and anxiety in patients on moving from ultrasound imaging to contrast-based imaging and more frequent surveillance tools. Here is Helio, GALAD, and AFP with ROC curves showing the superiority of Helio AROC in these two clinical settings. First is the HCC, all subjects, and in B, most importantly, early stage HCC. A little bit more data here on ROC curves, all subjects, subjects with early stage, and AROC for single tests as well as the combination. This is a really nice paper published recently at EASL 2022 in London, talking about a multi-target blood test making hepatocellular carcinoma surveillance programs more effective. This is a modeling-based study as opposed to a real-world and virtual trial using ultrasound AFP, methylated HBT, as well as HBT with a markedly improved adherence with improved utilization. Looking about this along the right side, we've got improved adherence, including showing another improvement in early detection from 44.8% to 47.5%. So methylation markers performed the best in these settings, and improved adherence also added to this. There's a little bit more data on new challenges as well as advantages of these modalities for hepatocellular carcinoma early detection. Highlighted here are advantages, challenges, opportunities, and future directions. This is a great review from Benamou in Gastroenterology 2022, including issues such as proteomics, extracellular vesicles, conventional radiomics, deep learning, and what's called probe imaging. Really want to highlight here the comment on radiomics, since we're mostly talking about biomarkers today, but advanced imaging with artificial intelligence also, I think, will be useful. So in conclusion, risk markers for HCC are extremely important. We're not planning to use these to replace imaging immediately, since ultimately HCC imaging is required for a number of tumors, vascular invasion, extrahepatic disease, as well as staging liver disease, staging portal hypertension. So I think imaging will be around for the long term, but keeping patients in an ultrasound surveillance mode, I think, is very important to decrease cost, radiation exposure with CT scans, keeping gadolinium exposure also down, and the higher cost of magnetic resonance scan. These biomarkers, I think, will be critical for early detection, and not just early detection, but also risk prediction, risk for recurrent disease, risk for vascular invasion, what you're going to decide to do in terms of intervening with systemic therapies, such as immune checkpoint inhibitors, using TKI, tyrosine kinase, or multi-kinase inhibitors. We do have challenges. These are protein-based. We still have sensitivity and specificities in the 90% range. Of course, we'd like to be closer to 99 or 100. But I think methylated DNA will be the next generation following the Fuji film triple panel, which was originally developed by Waco in California and collaboration with Wako's parent company in Japan. Circulating tumor DNA, including mutations, cell-free DNA also be important, extracellular vesicles, and of course, all of this is going to be done in combination with imaging. A little bit more here on biomarkers in terms of response or predicting response to checkpoint inhibitors. There's inflammatory hot tumors and non-inflamed tumors. It looks like these inflamed hot tumors may be more likely to respond to immune checkpoint inhibitors, and non-inflamed, non-hot tumors, such as what we see in a subset of patients with metabolic-associated fatty liver disease, may need multiple checkpoint inhibitors, such as a PD-1 or PD-L1 combined with CTLA-4, or using single checkpoint inhibitors in combination with their multi-kinase inhibitors. I'd like to thank Dr. Grady for the use of these slides, as well as AASLD, EASL, and a number of my gurus, including Dr. Amit Singhal, for all the work that they do in the setting of early detection for HCC, as well as my home base, the Hepatitis B Foundation. Thank you.